We are live now, doctor.
Okay.
A very good evening, everyone, and welcome to Research Matrix 1.0 episode 2. And just before we go on to our actual episode, let me brief you about the concept of Research Matrix. So basically, we over here want to introduce the concept of research very slowly in a proper and schematic manner for the young ophthalmologists, not with lectures, but with basic discussions with the expert panelists. And we've introduced the concept of debate in our sessions because we feel that it gives a perspective from both the sides. So whichever topic we take up, we talk about the pros and the cons of both the topic. So today we will be talking about where we begin. Often everybody has issues about understanding about what exactly do we start a research from. So this is just a panel where you will be able to understand where you want to really start from, whether it will be a research question or it will be data collection or how do you do a review of literature. So all these pointers will be discussed in our flow of the webinar. I request Dr. Apurva Yachid to please welcome our faculty members for today and including our debaters.
Thank you so much, Rolika, for having me for the second episode of Research Matrix. Can you see my screen? Yes.
Yes.
Okay. It is my pleasure to introduce first Dr. Anand Binekar. He is a luminary in the field of retina and an inspiration to all of us because of his tremendous work in retinopathy of prematurity. He has been solely heading it and screened hundreds of thousands of babies and actually saved sight for a large majority. He did his residency from PGI Chandigarh and has a PhD. He is obviously featured amongst the top 2% world scientists in the Stanford list. He has over 115 publications, including in the Lancet. He has won the Colonel Rangachari Award and many more, and also the Innovator Award by the Government of India. He is the founder secretary of Indian ROP Society and a member of National Task Force ROP. It's my pleasure to introduce our international guest, Dr. Simon Fung. He is the Associate Professor of the Department of Ophthalmology at UCSF. He has a dual fellowship trained in both pediatric cornea and external disease fellowship from the Sick Kids Toronto in 2016 and 17, and also at the Moorfields Eye Hospital in cornea refractive and external diseases. He has several indexed publications and he has awards that are too many to list. That includes the AAO Achievement Award and the Knights Templar Eye Foundation Career Starter Grant, and so on. So next is Dr. Sabyasachi Sengupta. He needs no introduction amongst the Indian ophthalmologists and even abroad because of his pioneering work in starting the Sengupta Research Academy. He is also featured amongst the top 2% world scientists, the Stanford 2024 list. He has done his, apart from his education in ophthalmology, so to say, he has also got a postdoctoral research fellowship and biostatistics from Johns Hopkins. He has been the past associated editor of IGO. Dr. Rituja Thomas Grover is a young consultant, orbit and oculoplasty, very active member of the oculoplasty scene in India. She's done her residency in NN Bangalore and has a fellowship in orbit oculoplastics, lacrimal, ocular oncology, and facial aesthetics
Apurva, just to interrupt, your screen is not visible. The screen share went off.
Okay. Has it? Okay. 1 second. I'm so sorry about that. It says it has to reboot Zoom. So
Okay, go on, ma'am. Don't worry. Fine. Yeah.
yes. Is it working now?
Yes, ma'am.
Okay. So there. So Rituja has several peer-reviewed publications, including book chapters, and has delivered several deliberations as instructor, invited faculty, and speaker. She serves on the editorial board of DOS Times and is the member of APSOPRS and National and Subspecialty Societies. And last but not least is Dr. Akshay Nair. He is a consultant at Aditya Jyot Eye Hospital, Advanced Eye Hospital, HN Reliance Hospital at Navi Mumbai. He has a fellowship in oculoplastics and oculo-oncology from LVPI Hyderabad and from Mount Sinai NYEE. He's also featured amongst the top 2% world scientists on the 2024 Stanford list. He has 140 plus peer-reviewed publications, 20 book chapters, and he is a reviewer for 40 plus journals. I think all of us remember him from the COVID time, where he had an entire slew of publications and spearheaded a lot of research in Mucor as well. He has the AO and APAO Achievement Awards, Best Paper and Poster Awards, and he is an executive committee member at APS, OPRS, and OPI. And the rest are Dr. Sonal, some of our research cell members, Dr. Sonal, me, Dr. Rolika, and Dr. Ayushi are, in fact, the main people of Research Matrix. They have started this, and kudos to them for doing it so well, and Dr. Anujit Paul. So we welcome you all to Research Matrix and hope you have a wonderful time learning and sharing.
Thank you so much, Apurva ma'am. And I'm glad that everybody could spare their precious time today, and we'll make sure of it that we go very much time bound. And so I request Dr. Rituja Thomas to share her screen, and she will be talking about the debate part. And so the debate is whether who came first, chicken or eggs. So whether it is about starting from the research question or data collection. And Dr. Rituja will be defending that research question is where we need to begin from. Over to you.
Yeah, I've shared my screen. You can see it, right? The blue.
Okay. Yes.
So today, basically, as Rolika said, what I'll be discussing is whether the research question comes first. Oh, has it gone? It's still there, right?
Yeah, it's there.
Yeah. Whether the research question comes first or whether the data collection comes first. So since I'm going first, of course, I'll be talking about the research question. And it's really difficult to sort of go for or against, because research happens kind of organically most of the time. So it's difficult to say which came first. But anytime you look for how to go about research, you always start with formulating a research question. And the midnight oil is always burnt by collecting data, especially as fellows. I'm sure all of us have done that work. Now, the world over, all researchers follow something called the scientific method. So, the scientific method involves asking a question that can be answered through all the data, and that's all measurable data. So, the 6 steps involve asking a question, doing the research, making a hypothesis, and then collecting data to show how your hypothesis fares, and then drawing a conclusion and then checking whether the hypothesis was correct or not. And this is how most research studies are designed. So, what is a research question? The main aim of the research question is to guide the direction of the research. So, for example, what's the effect of anti-VEGF therapy on macular edema in diabetics? Or how does intraocular pressure fluctuate in patients with glaucoma over time? These are some simple questions that require to be answered. And it's the basis for designing the method and analyzing the results. So, how do we benefit from a research question? It prevents unnecessary or irrelevant data collection, and it helps you select the appropriate tools for the data gathering. Usually, this is the framework which is followed to make a research question. And if you follow these things, that is, what is the target population? What is the intervention? Is there a control group? What are the outcomes? And what is the time frame that the study will take up? These things help you come up with a fairly good and complete research question. Now, if you start collecting data first without an aim, you may collect irrelevant or unusable data, and you may waste resources in this process. For example, if you collect extensive CT scans in a study where you need to check for field changes in a patient with thyroid orbitopathy, that's just an example. So it also helps you decide what tool or machine you need to use for the data collection, and then you can go ahead and analyze the data accordingly. Now, you may say that in retrospective studies, there is already a lot of data present, but this sort of is helpful in studies, especially where it would not have been feasible to do this study without having gone retrospectively. For example, in people who had cigarette smoking as a risk factor. So, we can't make people smoke cigarettes to see if they develop lung cancer or not. So, it's helpful in that case. Now, having a database is great. Database is where information is automatically collected and archived. But sometimes databases can have increased costs because of the software, the hardware, all the trained personnel that goes into maintaining that. And sometimes, if the database fails, it can have a negative impact on operation. So, making observations is not the same as collecting data irreverently. So, for example, when penicillin was discovered, it wasn't that everybody was going around culturing fungi along with bacteria. It was accidentally discovered in bacterial colonies. So, that was something which was observed, and an observation was made which led to the incidental finding. So, for example, in what I had mentioned earlier, in anti-VEGF therapy, you would do the OCTs, do the vision tests and the outcomes. Or in glaucoma, you would do IOP measurements, adverse event reporting, and long-term monitoring. So a clear research question leads to a targeted data collection, and that's basically what you need. Making sure that you align the question and the data collection ensures efficiency and gives you meaningful results. This is what I feel. However, research is a very complicated thing, and you may collect the information first, or you may make the observations first, but it's important to ask the right questions at the right time to make sure that you're going in the right direction. So we can argue about this, but I'll hand it over to Dr. Akshay now.
So now we will request Dr. Akshay for a subtle rebuttal.
Subtlety is not my style, but I'll try.
That's why I said subtle rebuttal.
Right. So Rituja said that prematurely, having a question in mind will help you focus on your topic. But I think prematurely framing a definitive question will impose artificial constraints, and it narrows the scope of your discovery. Things that you may not even know about, trends or patterns, will not be visible unless you collect the data that is seemingly irrelevant, but is still in your collected data set. Sometimes when you collect data, and as the data comes in, and that's when you see these patterns changing, that can guide you towards a more coherent research question, or it could even change your research question. And about resources, gone are the days where we are going to open paper files, fill out an Excel sheet manually, 1, 2, male, female, age. Everything is automated nowadays. So automated data acquisition from electronic medical records based on your filters and the integration of them into data analysis softwares, resources, I don't think is any longer a question. And just to give you an idea, there's this paper published in JAMA, which was across North America, Canada, and US, from departments of urology, surgical oncology, anesthesiology, plastic surgery, and a lot of public health experts as well. They wanted to investigate the factors that affect readmission rates, resurgery rates, and death amongst patients who go in for normal surgeries, regular surgeries, nothing unexpected, nothing like a gunshot wound or a trauma. Simple surgeries. They enrolled 1.1 million patients in their study. They looked for type of surgery, whether it was emergent or elective, or the complexity. They looked for comorbidities amongst patients, age of patients, sex of patients, days of admission, the type of surgery, whether it was urology, plastic, and whatnot. Do you know the only factor that affected the rates of readmission, resurgery, and death? The gender of the surgeon. Female surgeons were found to have a significantly lower readmission rates, resurgery rates, and death. Now, in your Excel sheet that you would have set out to go, do you think this would have figured? Probably not. So again, what my point is that you don't go in directionless without a head. You have a general idea in which you want to research and collect all the relevant data and then make sense of what comes out. And then you can, distill that data into a conclusion. And the paper that they published was Surgeon Gender Affects Surgery Outcomes. And this was certainly not what they thought of when they started this project, which is, I think, a fair, gives you a fair idea of how the question that they sought to answer was completely different from the answer that the data gave them. And this was only because they went with all, with absolutely no blinders on their eyes and collected all the data possible of 1.2 million surgeries over a 6-year period.
Right. That you definitely mentioned that subtlety is not my style. Right. And
All
I
right.
would just like to take the opinion of Dr. Simon Fung on this topic. What would you say, Dr. Simon? Do you agree? I mean, how would you put across Dr. Rituja's statement of backing up the way to go is research question formulation? So do you agree with the same?
I think as a third party, we always have to go somewhere in between the two speakers. I don't think there's actually a right or wrong answer. I think you can also, we can also argue that, if we don't look at any data at all, or like Dr. Nair was saying, if we don't look at the data that's outside the data sheet, we'll never find the answer. At the same time, one could also argue, like what Dr. Thomas is saying, that if we don't have a research question, we might not even start looking at anything at all. So I think I like the quote that Dr. Nair was saying is that don't put on the blinders. If you have a research question and you are collecting the data, don't always ignore the things that are not on that sheet. Don't ignore things that are otherwise detected in signal. It may be that when you're setting up the research in the first place, be a little cast a slightly wider net and not just be so too focused or overly focused into the research subject.
Yeah, we would agree. And we can go ahead with Dr. Akshana's debate part. And I request him to share the screen. And here we will be talking about he will be defending from the point of view of data collection. So over to you, Dr. Akshay.
All right. I hope my screen is visible.
Yes.
So while, of course, we are debating the whole idea of whether the research question or the data collection, the chicken or the egg, whichever we are, I'm certainly not going to be chicken about talking about in the presentation. At the end of the day, this is an academic exercise. The whole point of this is to convey the importance of having a concept in mind and the importance of data collection. I will give you that a general direction is needed. And the whole debate is whether you have to have a laser focus on the question in mind, or do you collect the data and then look for associations? Rituja mentioned cigarette smoking increases the risk of heart disease, and you can't ask people to smoke prospectively. We know that first statement is true. The second statement of cholesterol with elevated blood pressure is increased with risk of heart disease. Exercise is associated with a decreased risk of heart disease, and obesity causes an increased risk of heart disease. LVH is associated with stroke, and elevated blood pressure can progress to heart failure. These are questions that I think a class 12 or a first-year medical graduate would be able to answer. But do you know how these came about? There's a small town called Framingham in Massachusetts, close to Boston. And until 1948, they just knew that there are some factors outside our control which could affect cardiovascular health. And they enrolled about 5,000 people in the town. Everything and anything about these people and their lifestyles was collected. They were followed up for 20 years. In fact, now we have O2, O3, which is generation the second generation of the original cohort, and the third generation of the original cohort as well. In fact, the Framingham Heart study is the study that coined the term risk factor. We didn't know that term till before that. And the only broad concept that they had in mind is, do you think maybe cardiovascular health is affected by external factors? They had no idea on what data to collect. So they went about collecting all the data possible. And that's how they came with those conclusions. My personal experience during my residency, I was working with Dr. Rashmin Gandhi, and he said, 6-nerve palsy patients come in, we do neural imaging in all of them. Nothing really comes out. We just, nothing changes the outcome. Do you think neuroimaging in 6-nerve palsy is really useful? I said, okay, we'll do a study. And we collected the data. I said, what data do we collect? He said, everything. And that's how we went about collecting everything. And we looked at non-traumatic isolated 6-nerve palsies in patients who were 40. The imaging findings showed nothing positive that could suggest that imaging is actually indicated. But because we had collected everything and anything about these patients, what showed up was that in patients under 40, if there was a history of multiple sclerosis, a prior history of cancer, or over a 3-month period, a worsening of 6-nerve palsy, along with gradual involvement of other cranial nerves, these are the risk factors that would absolutely indicate an intervention. And that is the data that we could distill because we collected random information about, when I say random, it means everything that was in their file. And what we came up with was this paper, the diagnostic yield of neuroimaging in 6-nerve palsy. We have proposed an algorithm of imaging in 6-nerve palsy, which gets followed to this date, all because we just knew 6-nerve palsy, collect all data. And that's how we could distill this into something. At the end of the day, if you go ahead with no focused question, but just a general direction and collect all the data, you're promoting unbiased discovery. You're looking for associations that you didn't know that could happen. You could facilitate complex, multi-dimensional, multi-speciality analysis. About, when I say resources are no longer a problem, that's because we have access to great AI and big data analysis, as well as, computers that can help you make sense of all this data. The data provides basis for cross-disciplinary research. It identified trends early, like in COVID, when we didn't know what are the risk factors, whether, or the tocilizumab or ivermectin or whatever drug you knew, does it work? Who are the people at risk? That's because they collected anything and everything about all COVID patients, and that's how they came up with the at-risk population. At the end of the day, all the data that you collect, you may answer your question, but that data set can be used to answer questions by others that they are asking. So to summarize, I'm going to say that, to go in with absolutely no research question in mind is foolishness. I'll give you that, Rituja. But what I'm saying is don't focus in on a question. Have a broad concept in the direction of your area of research and collect all the data. Don't disregard seemingly irrelevant variables, because at the end of the day, you have to be inquisitive. Data for the question that you ask will yield answers to that question, but data beyond your question will give answers to questions you never asked in the first place. And at the end of the day, I don't know whether you want to ask about whether the chicken came first or the egg came first. They land up in the same place. Thank you.
That was a fair defense, but Rituja, would you like to say something about the same?
Yeah, so even if there is data already present, for example, like you said, for mucor. So if you don't have a question in mind that what is the risk factor causing mucor, see the data which you talk about, that they were diabetic or they were immunocompromised in some way or whatever. These are all things that come automatically in the data collection, because it's already in the charts of the patients, because since everything is automated now. But I would say automation isn't easy in every setting. For example, in some of your patients who were in medical colleges, it had to be looked at individually, that what all risk factors did they have. It had to be collected separately. So that was a question which to which people were looking for answers. And when you have so many risk factors, it's like looking for a needle in a haystack. So it's important definitely to have that much information. Now, the Framingham study that you mentioned, that is, of course, something which answers a question which is much older now. It's very basic, as the Gen Z says. So things are much more evolved. We're looking for much more pinpointed things, looking at echocardiograms more, with more closer measurements and things like that. So that's something which, people were collecting earlier. And when you say that you can do multiple studies from the same data set, it's something actually that when somebody starts a big study, they tend to actually organize it in that manner, that they have so much of data in different types of data, and then they actually plan to have different studies under it. So these things, I would say, are a little pre-planned. However, yeah, the point is definitely moot, that it happens when it happens, or it happens however it happens. Like how you decided to look at the sixth nerve data. You decided to look at it, it happened. And now, for example, in my thesis, when I went to Dr. Anand for a topic, because I was really interested in ROP at that time, my thesis actually came about because Dr. Anand was given a set of contrast cards by a lady named Dr. Angela Brown. So she had given him those cards in Arvo. And when I went to him, it was like the right place in the right time. And he said, I have these cards. Why don't you test them out on the ROP and non ROP babies? So uh, it it can happen in any way. So we got the cards, so the research happened, but we weren't actually thinking about contrast sensitivity in ROP before that. So yeah, I would say that's about it. But I think it does require some amount of direction right at the beginning before you start looking.
So I think I think the essence is that whether it's not important whether the chicken came first or the egg. It's about how you approach your research, and if you do it in an ethical fashion, and if you do it in a regulated manner, whether you're collecting data first or you're talking about a fine research question, it should just flow in the organized manner. Is that correct, Dr. Vinekar? Would you like to say something as well?
Yeah, I think both of them are right. And I would just, yeah, absolutely. I think the ethics is really important. When I was listening to this question answer debate, one very interesting quote that I heard many years ago when I was a resident came to mind. It was an IFS officer, and he said, "When I was young, I thought I had all the answers. Then, when I grew up, I realized I had not even understood the questions." And I think that kind of gives us a very deep perspective, not just on research, but on life, that we have to ask the right questions to reach the answers we think we're reaching. But if, as Akshay says, if we don't have the curiosity or this element of serendipity, where things just show up, you look at patterns, you can talk about automated data, but what about observations? What about a finding? What about a retinal finding? What about an observation of of something that you can't quantify in data? And those findings, when you relate it to causation and cause and effect, that cannot be done with just having a research question in the beginning. So I think it's a mixed approach, and both of you were great. Learned a lot. You guys debated really well.
Thank you so much. Thank you so much, Dr. Venekar, for your inputs. And Dr. Sanisa, would you like to say something as well? Dr.
You're on mute, Sunny.
Sanisa, we cannot hear you. Probably the audio is not connected.
I think you can hear me, right?
Yes, yes.
So basically, I would not like to say a few things. I'd like to say a couple of things only. First and foremost, let's look at study designs and what is at the top of that food chain of study designs. Let's all of us will agree that randomized trials are right at the top of that, isn't it? And then we look at prospective studies, and then we look at retrospective studies. Now, if you want to do a randomized trial, you can't start with data. You have to start with a question, and that to an extremely well-defined, very, very precise question. And all of the other paraphernalia have to be knocked out, isn't it? So you need to exclude a lot of things which could be potential confounders, isn't it? So then you can't do a randomized trial without a study question. You have to start with a question. The data will come and then it will prove or disprove that question. You could do many other things because you are perhaps collecting a lot of data. Now, the question here isn't whether you are looking to collect limited data or infinite amount of data, because that is a no-brainer, right? You will collect whatever there is available to you, and as put forward not so subtly, that collection of data is pretty easy nowadays, right? However, if the study question is not right, you can't do a randomized trial. You can't even do a prospective study, right? So then a study question really becomes important, and it is advisable for all the young ophthalmologists listening to us to have a study question in mind and not just all and sundry. So have a study question in mind is very, very important. Design that question very, very carefully using the PICOT approach that Rutuja showed us in the beginning. And, so you can, of course, do a lot of analysis and this and that. So, therefore the study question becomes of primary importance. Do you think your paper will be published if the question that you ask is not novel enough? It won't see the end of the tunnel at all. So study question really becomes important there. Even if you have the data with you, the kind of questions that you're asking is going to guide the statistician or you to do that kind of statistics. It could come up and say, oh, I was looking for this, but that came up too. But then only that coming up is just serendipity, and as we know, that doesn't happen. That's not a common occurrence. Though, when you look at a lot of inventions, that is a major occurrence. But then in daily life and in daily papers and research, that is not a common occurrence. So then we want to start with what are you looking for? Radiologists will not see a small tumor if you are not telling him to look for it. So then what are we looking for is something that we need to always have in mind, and that is the blueprint on which all the data can dance around, and we can play around with that. A couple of statistical things which we should perhaps we should know and that we don't think about is if you have a retrospective study and you're starting with data and you have a lot of data, like 1 million patients, any and every minute difference will be statistically significant. Let's take an example of intracameral moxifloxacin for preventing endophthalmitis. And there is a study from 6 lakh patients in one center, where 3 lakh received and 3 lakh did not receive intracameral moxifloxacin. And what were the differences in the rate of endophthalmitis in the two groups? It was 0.05 and reduced to 0.02. So you can see the treatment effect. It's a very, very minute effect. It's like, but if I have 6 lakh patients, even if it was 0.05 and 0.049, it would still be hugely statistically significant. So the sample size is also something that we need to define and play around with, and that will also tell us a lot of So if it's a 1.1 million patient study, what will come out perhaps is almost everything which could be significant will be significant. So a lot of the time that could be spurious too. So retrospective data or studies which start on data and come up with outcomes which we think are useful will be looked at as hypothesis generation, and that's about it. You need to start with that question. Oh, that looks interesting. It's true. Is it true? Let me do a proper study. So you start with that question. You can generate questions by starting with data, but you can't actually make dogmatic statements by starting with data. And last but not the least, when we're looking at these other things, we started with a primary question, but we had all of this data, and we are looking at a lot of these other outcomes. We didn't start to look at them, but we're looking at them now. We call those post hoc analysis. So post hoc analysis is different from, we could spend a long time discussing what is post hoc analysis, but the main difference is, the study was actually designed for something else, but now we are basing it on something else. So that is called post hoc analysis, and that is something which the purists will say, the study wasn't designed for it, and therefore the outcomes, though significant, are something that we would, be skeptical about. And the last statistical concept is looking at the power of the study. If you're starting with data and you find something significantly different from the other, now is this study powerful enough or powered enough to find that question or find that answer? Is something that every retrospective study should publish in their results. Unfortunately, we don't see even 1% of them doing so. So overall, I thought I'll bring some of these aspects into focus when we're discussing what to do.
Right, sir. Thank you so much for the statistical and the insightful part of it, because sometimes we often don't notice that part, and the nitty-gritties of data collection and the nitty-gritties of what impact it does on its final analysis. It's very important for us to know. Is my screen visible? I would just ask.
Yes.
Right. So, as Dr. Simon would be leaving very soon, and he has other commitments, I would just proceed with the case scenario for Dr. Fung. So, the case scenario here is that you've been asked to recreate the educational program in your department in ophthalmology. And before that, you would like to carry out a research to analyze the existing issues and the required solutions. I mean, yes, of course, you can have it like in the standard modules of how it used to be earlier, and make some changes. But you decided that you would like to go in a methodical way, and you would like to conduct a research. In such a situation, where would you begin, and what all researches would you like to do?
Thanks for the question. And again, apologies, I have to leave early, but so we'll get this cracking right away. So I think it's actually funny that how this sort of fit into the earlier session where you already have a question and how do you go about. I think really at this point, it would be nice to actually have some kind of data and a data collection from the prior years or from the current trainees, for example, to see where the issues are and what are the problems that we can actually identify that are worthwhile analyzing. And then knowing what those questions are, then we can then formulate the more in sort of like a nuanced research question or study question. So to take an example that we want to recreate, let's say the residency training in surgery, for example, we wanted to first of all think about, well, what kind of surgery are we talking about? Are we talking about retinal surgery, well, which was probably maybe outside the scope of many people or many trainees, or are we talking about cataract surgery? That may be something that's very applicable to every single trainee. So you kind of want to know what your background is. And secondly, is what is the current exposure? Are people doing a lot of it, not so many of it? I've had in real life examples I've had in different countries where residents may not be doing any surgery at all versus residents like in India where they're doing a lot of cataract surgery. So you're going to want to know what is the current exposure, and then you can define, well, how do we then improve afterwards. I think the final thing is actually very important before we sort of design all the researches that we want to do. Is actually think just like earlier on what Dr. Na was saying, even though we want to think about, well, I want to know, let's say, surgery numbers, how can I improve the surgery numbers, do consider other things that we may not have actually thought about. For example, what about the trainee's perspective and how does that affect their, for example, everyday lives and their work-life balance and so on and so forth. That might not be immediately answering your research question on your quest to recreate the educational program, but it will definitely impact how effective your program is. So be a little bit open-minded about what data you want to collect and think a little bit outside the well-treaded path.
Dr. Fung, do you think, along with the inputs that you've given, do you think questionnaire-based studies in this situation would help? Like, would you prefer to carry out a questionnaire analysis of the the previous residents or the fellows, and then assess what parameters that they would require going in future? Do you think those can help?
I think certainly it'll help at least, at the very least, to set the scene, because if you don't know what you don't know, really you cannot go anywhere. I think the famous quote is that you can sort out the known unknowns, but you cannot sort out the unknown unknowns. So if you don't actually know what the question is and what the problem is currently, and that's where the survey really comes to handy, it'll be very difficult to actually do anything that's meaningful. You may be carrying out research that you think is very important, but it may not be important to the people who you're trying to impact on.
That is true. Thank you so much, Dr. Funk, for your inputs. And we hate to see you leave, but I do understand that you have other commitments, and we will join with you again in future. Thank you so much for
Thank you so
your
much.
time
Yeah.
and for joining us. Thank you.
Yeah, thank you so much, and apologies I leave early, but it's a great session and hope that everybody can learn a lot more. Thank you.
Thank you so much. Thank you. So we move to the next case scenario, and that would be for Dr. Anand Vinekar, sir. So this is a pretty much an extension of the debate a little bit, but it's we would like to see your perspective. So you have a data set of more than 5,000 retinopathy of prematurity patients, and I'm sure that you have probably more, and treated over your career. You have observed an association over time between two factors, and you know that it's going to be there. It's like your gut feeling. It's like, I have seen this. Of course, it exists. And I'm sure that you have more of such associations that you must have noticed. What would you do? You would collect a large variable, a large set of your presentation of your patients so that you can analyze other factors as well to produce more possible papers. Or you would specifically collect the data on research question that you are looking at. And I know that this keeps you in a dicey situation, but what would you do?
Thanks, Rolika, for that challenging question. So I'll just dip into some personal experiences in handling some of those. Maybe that would answer it and we could keep the discussion alive. It happened more than a decade back when we saw this baby who needed to be treated. And at that, this was the pre-anti-VEGF era. So we had actually decided to go in and laser. And we had seen it on Saturday, and we were going to go and laser this on Monday. And when they brought in the baby before doing the laser, I had a look again, and the disease had disappeared, or at least really, come down. And our first thing was, have you brought in the right baby? So yeah, it was right. And then what we figured was what looked at that time, what we now call aggressive posterior ROP, had really diminished. And we were really puzzled on why that happened. We went back to the file, and the only thing that had happened in those 24, 48 hours was the baby had received a platelet transfusion for thrombocytopenia. Now, that didn't seem like any association at all, but the baby didn't need treatment, so we sent the baby back and we followed up after a week, and the disease never came back. But that thought about could platelets be associated with aggressive ROP stayed with us. We said before we look back into a larger retrospective data, let's look in the same center. In that center, we were screening for more than 8 years at that time. And so we said, let's pull out all the similar looking disease, the zone 1, what we think now call as aggressive ROP, and see how many of them had low platelets. Of course, we had treated all of them in the past, but let's look at that. And we found that 85% of them had low platelets, and more than 80% of them had less than 50,000 count. And many of them had probably received transfusions just after. So when we saw that, we said, okay, now maybe there's an association. So that was like finding a finding when we didn't expect one, and then framing the research question whether low platelets is a risk factor and why. So the why was even better. When we looked at the granules in the platelets, we found that they have alpha granules and beta granules, stuff we learned in physiology. And the beta granules actually produce substances that are equivalent to anti-VEGF. They have that property at least. So what the baby underwent, the index case, was that because of the platelet transfusion at the right postmenstrual age, actually worked like anti-VEGF in the blood, and then that must have reduced at least the severity of the disease. So then we took on a very long study, and you won't believe that low platelet as an independent risk factor came out of our group and then became a very large multicentric study across the world. So that is one way of doing observing a finding and then doing a cause and effect. The second interesting one to answer that second one in terms of the data was while we were using handheld OCTs in ROP, and we had this idea that, of course, we want to image the ridge. We want to see whether we can do the OCT and find out whether it's a stage 2 or a stage 3 based on how its OCT appearance was. And this was, again, over a decade back. And while we were trying to image the periphery, quite accidentally, we found macular edema, or what looked like macular edema, and that was not described before. So, and then we started seeing two distinct patterns. One of them looked like the classical cystoid macular edema, complete disruption of the foveal area. And the other one looked like hyperreflective spaces, more like schisis, just outside the fovea. And we didn't have any clue on what to do. We didn't even know whether to treat them or observe them. So we just observed them, and they went away. We saw them at the peak of 37 weeks. They went away by the 52nd week. So we said, okay, this is transient edema. So the question came, why aren't other babies seeing it? Why aren't we seeing it in other babies? And does this partial transitory disruption of the foveal anatomy affect vision? So we started following up these babies, and then we started, of course, having controls of babies who did not have edema, and then we started having controls of babies who didn't have ROP, and then controls of babies who were not preterm at all, and found that even though this was a transient edema, they influenced vision at the third corrected month. And then we started looking back more prospectively on what all these OCT markers can be. Interestingly, the Duke University found that that second pattern of edema might actually be linked to a neurodevelopmental impairment, including autism and cortical vision impairment. So I think your question about whether the large data set is variable to analyze other factors, yes, absolutely. But sometimes you need to find that one observation that will guide you to looking into your larger data set. And then several more papers can follow. I hope that's answered some of that question.
Yes, sir. I think I agree with you too. And I'm sure that Sunny sir would mention that it would affect the statistical analysis eventually. But there are certain associations which probably cannot be explained in words. They're rather your clinical experience, and they're rather, and something that you have collected already mentally over time, and you probably have had the research question mentally for the longest of time. That's why it's okay to proceed with a large data set collections. Of course, it's going to be a task for the one who's collecting it, so God bless them. But at the same time, it's a very important information that you will be adding to the literature as well. So I mean, if you do not collect large data sets, and if you do not put that out in the existing literature, then what's the point? So of course, many associations can come out, and I would agree that many possible papers can come out, and that is definitely not salami slicing. So another part there. So we can move on to the next scenario. Thank you, Dr. Anand Vinekar, sir, for your inputs. We will have a mutual discussion at the end as well, because we would require your inputs. And Sunny sir, this question
Monica,
is...
can I
Yes, sir.
just butt in and give it?
Absolutely.
So, over a period of a decade, I have realized that you need to first, let the data speak and then make up your mind. Don't make up your mind and then make the data speak. And that is very possible. If we listen to everything that our brain says, that's what is going to happen. Oh, I think, over the period this is what I've observed, and I think that's how it is. And then your data is for sure going to say the same thing. But then try and not get into that rut, because it's like if you make a mistake once and nobody's pointed out to you, you're going to make that mistake over and over again. So so the overall message is that even if you're looking at small or large data sets, let the data speak, look at it in an unbiased fashion, and then make up your mind, instead of making up your mind and then looking at the data and saying, So I mean, this is a very subtle difference, but it makes a huge difference in the way we are interpreting things.
Yes, sir. That is also a correct point. Like sometimes when we are collecting data in such a way, we have a set bias in our own zone. But of course, if you have multiple variables, that bias will get, mellowed down. But if you collect data of just those few specific variables, then you're, of course, creating a biased data set, right? Thank you, sir. And Sunny, sir, we would have the next scenario for you. So you have received a research grant for a groundbreaking research idea. And however, the research grant team, and you have a set protocol for the research. However, the research grant team would like you to make some modifications in your methodology, which changes your submitted protocol based on their requirements. And again, this is, before I would clarify that this is an industrial-based study that you're doing. So you have applied for the grant, you have taken you are supposed to take the grant from them, but they want some changes in your pattern. What would you do in such a situation?
So I would really sort of look at it in two large scenarios. One is that it's an industry sponsored or a pharma sponsored grant that you are taking, funding from a pharma company, and predominantly all clinical trials, even if not sponsored by pharma, are almost all the top authors are consultants to this pharma and that pharma. So that is one scenario. The other scenario is that you are getting a grant from, say, an ICMR or an NIH or an RO committee or something like that. So the two different things that I would look at. So, slightly two different scenarios, as you can imagine, where a lot of, commercial and financial interests do come into the picture. But, having said that, the approach would still remain the same. I would tend to look at whether this is going to likely, influence my outcomes. Is this interfering with the sort of final conclusions that I'm going to make, or, so if they say, okay, you have a 1 year follow-up, but you should look at 2 year follow-ups maybe. And that's all right. That is good, maybe, so not all the advice that they give you will be bad, so then if they say something like that, then it's very doable. But then if it's something like, if they say, okay, you are looking at these two groups comparing across, but then we want you to add these additional exclusion criteria and then do the study. And if some of those are likely to influence my outcomes, then that is something I would not be comfortable agreeing with. So that this clarity will come in only when you define that outcome measure very well and think about every possible aspect of what could influence that outcome measure, and then make your decision based on whether you think that is going to influence your outcome measure. And that is where the industry sponsored study will come into question, where you will realize more often than not is that they are trying to actually bias you towards a particular outcome of their own interest. And so that is more common in the industry sponsored trials. So I would look at whether this is going to influence my outcomes, and the kind of, if I say the drug is not good versus, I'll give a quick example. So if a company says, you're looking at cystoid macular edema of whatever, and you're comparing my drug versus an existing drug. So I'll say, okay, I'm talking about cystoid macular edema reduction with at least, I'm going to say it's a yes, no. And I'm going to say at least 10% reduction from baseline. If it happens, I'm going to say, there is reduction. And if there is not enough, if there is not 10% reduction, I'm going to say there is no reduction. It's just going to be yes, no. And they might say, no, don't look at it as yes, no. Just look at it as an absolute number. 5 micron reduction, 7 micron reduction, 10 micron reduction. Versus, so you would say one group reduced by, say, 30 microns, plus or minus whatever. The other group reduced by, say, 40 microns, plus or minus whatever. And so when you look at the second outcome, it's a continuous variable. And even 30 or 40 micron differences may not come to be significant. And you will say, oh, both drugs are the same. But then if you're looking at the prior outcome where I'm saying 10% reduction, you will say, 13% responded versus, say, 28% responded. And therefore, one is better than the other. So if somebody is tampering with my outcome measures and things that will influence my outcome measures, including definitions, I'm not okay with that. Or I will have to go back and see whether they are making more sense than me. And if you have an open mind, that could also be. Right? So, more often than not, the better suggestions would come from an NIH or an RO committee. And the more relatively more biased, suggestions should, but still that does not mean you just outright reject it and say, oh, I'm too uptight and I'm going to not listen to the pharma. If you want to, dena hai to de, varna mat de. That's all right. But then, they could actually make a lot of sense too. So then, that depends on what they are actually asking me to do. And so the real take home message is, if they're asking me to change my outcome measure and things that will influence my outcome measure, I'm perhaps not going to be okay with it unless they are making more sense than what I was. And I hardly doubt it, because I've put in a lot of effort to create that protocol, right? And the second thing is, if I'm looking at, something other than an outcome measure, and if it's coming from the pharma, I would really look at it more skeptically. And if I'm looking at somebody like an ICM or an RO committee, I would perhaps look at it more favorably. So I don't know whether that makes sense, but I think, given short notice, this is what came to my mind.
No, that's absolutely correct, sir. You have put on all the pointers together. It is important sometimes to, and as you said, maybe they are also trying to make some sense, and it's okay to look at their perspective because they've been in the field and they probably know what they're talking about. But I do agree that a committee or a meeting should be held in such a situation to have a discussion, and it's important for you to be able to put your points forth because eventually you have to do the research and you should be comfortable with it. And if you are not comfortable with the whole situation, probably the research outcome is not going to be as, authentic as you would like it to be. Dr. Vinekar, would you also like to say something?
Actually, something absolutely similar has happened to us. It was for a biosimilar for anti-VEGF for ROP. And it was a multicentric trial, and we were one of the inclusion sites. And when they were making the methodology, they wanted us to use the American screening guidelines. And I was like, no way, this is an Indian biosimilar. You have to use the Indian cutoff, whether it's the birth weight or the gestational age. So again, those things are very big. They would influence the outcome. And the second one is that they were talking about safety, but you have to at least follow up the babies for a decent amount of time and not the very short period that they were recommending. So again, we fought on that and then made sure that at least it was midway between what we wanted and what they wanted. The final one, of course, is something that we wanted and they couldn't get it. And they said, okay, you do it, but you make it out of protocol. And that was to use angiography at the end of the follow-up period to actually determine the amount of avascular retina pending. But we realized if we had insisted on that, many centers who don't have the fluorescent angiography couldn't be included. So like Sunny said, sometimes we have to go and walk the midway and say, okay, these two you agree because they are really important and they shouldn't influence outcome. But the other one we let go. It's okay. We'll do it out of the protocol, but we won't insist that every center does it. So I think, yeah, absolutely. That's been the experience.
That's interesting. So thank you for sharing that. In fact, it's important that everybody realizes that research is not really just getting a paper out of something. It's like serious business, right? When you're dealing with adding information, it has to be authentic. It has to be worked on, and you have to put your foot down sometimes in the research flow. Like, if you're talking about the methodology, it's the most important thing because as you said that you were like, no, American guidelines do not work in India, they're not applicable. So these are the grounds on which you can actually debate and you can actually discuss with those grant teams that it might not be it might not be the correct solution to what they're looking at. I do agree with you. Would you like to add any of the pointers before we call it a day? Either of you, would you like to say something?
Just like to say that all the young people who are going to be publishing, numbers are important, but they're not at all important compared to doing it right and doing it ethically right. I remember my time in PGI where we were publishing a person who had completed his thesis and gone, and that person had not published, so it came on us to publish. And that paper was almost getting accepted, and just the penultimate, reviewer said, just please look back at your statistics because something seems wrong. And that's when we realized that the Excel sheet was kind of wrong, the way it was collected. And we withdrew the paper because my mentor, very rightly put in that work ethic that it's really wrong to put out information there which the world is going to use, which is wrong. And you'll never have a decent sleep at night if you've put that out. So ethics comes really number one. And sometimes that means standing for what you think is right. We've had the occasion where we did free screening for term healthy babies, and we sent that up to a journal, and we just had 46% enrollment. 100 babies we offered free screening, and only 46 said we want to get it done. And the reviewer said everything is good about the paper, but how come when you're doing it free, only 46% have said yes to your screening protocol? And I had to tell them that that's not the way the world works. There's something called health-seeking behavior. And so they basically rejected our paper only on that premise that we didn't have good enrollment, even though everything else they agreed. So I wrote back saying, this is the real world, and health-seeking behavior is not always when something is free, everyone will flock for it. And they read that letter and then they accepted for publication after, rejecting it 48 hours later. So sometimes it's really important to stand for the integrity that you believe in and keep doing the right thing.
Right. I do agree with that point. Absolutely, Dr. Vinekar, because recently I landed up rejecting 5 of our own, the papers that we were working on because I went back and I was like, there is something wrong with the data set. We cannot move forward with this. I was like, either the entire team, requires to collect the data again, or we go on, move on with a different parameter over here. I agree with you. The ethics part is extremely important. It's not just about putting a paper out there. It is probably not going to benefit anybody. It might just benefit some people in, going ahead with promotions, but you're not doing research for promotions. This is what we mentioned in the last episode as well. It is about putting good literature and scientific material out there, which is useful for the people who can do research forward as well. So whatever you're going to add to the literature now is going to be useful for somebody else tomorrow while they're reviewing their own papers. So we are adding science here, and not just for, a number of publications, as you said. And it's okay to step out of papers where you don't think that they're ethical. It's not a big deal. I agree with you. I've done the same, and I'm too young and I'm doing that. It sometimes feels that, too young and you're making such a decision of not being a part of a paper. I don't care. I would agree with ethics as my primary part. Like, if the paper is going well, I would be a part of it. Otherwise, it's okay to move on. Would you like to say something, Sunny sir?
Yeah, so, of course, ethics is something that we can't compromise with. The other thing is, whatever comes first, the data or the question, finally, we are the one who is going to make sense of what we're finding out, right? So it's important to have a, balanced view and make sense of what you're seeing and not you believe, and what you believe in, like I already said before. So the cornerstone for that is to therefore believe in the numbers and statistics, and not just on the hunch, or your own belief. Don't,
Right.
there are plenty of books which have been written on don't believe what your mind is telling you all the time. So
Right.
Thinking Fast, Thinking Slow is another fantastic book where you say, oh, a lot of patients say, oh, I have got injury, therefore I'm not seeing well. And that we see very commonly, isn't it? But then perhaps the diabetic retinopathy has no relation to injury. They say, oh, I rubbed my eye or I slept on that side, therefore I can't see today. But then, that's a time bomb which is there in your eye for the last like a decade or so. Right? So don't believe everything that your mind tells you. Go out, seek data and analyze it well, make conclusions based on what the numbers are saying and not what you are believing, and then therefore prove or disprove it to yourself. And that's pretty much what methodology is. And lastly, the importance of an optimum sample size is really, really important. If you if you start with data, there is a tendency to collect massive amounts of data simply because it's available to us. And there is a statistical term called inflation or an overinflation, which of course all of us understand in terms of finance, but in terms of statistics, that inflatory effect will cause anything to be significant. Like I already gave you an example. And the other end of the spectrum is too little a sample size, where even large differences are not significant. Right? So we want to have something which is optimum, where you have a good question, you have the requisite data and maybe more data, and everything is in place, and everything is in balance. And no matter how you look at that outcome, you could redefine it, and you could define it in one way. You could hold the nose behind your head or in front of your head. You will get the same outcome every time, and that is the absolute truth that we are seeking, and that is what we actually need to seek. So overall, I think whatever comes first, the way we interpret it is what we are going to put it out there. So that is what I thought I'll end with.
Thank you so much. And I thank the entire team, Dr. Rituja, Dr. Akshay, Dr. Sabin Fung, and Dr. Vinekar and Dr. Sunny Sengupta, sir. Thank you so much for being there. And, our topic for today was that where do we begin, right? What comes first? I think a good intention comes first. And if you have a good intention, you can proceed with, that's the essence I've gathered from all of you, that you have the good intention. If you have a good methodology, you can go ahead and do research. And please do not refrain from research. Do not get scared of research. It's kind of fun. When you begin, it might seem a lot of work, but when you start going through it, you will actually enjoy it, because when you see outcomes that you've never seen before, when you realize that, oh, I'm getting information which never existed before, it's a different kind of rush. So I hope you all enjoy research, and I hope more and more of you do research. And I promise that it will end on time. We will start at 5 minutes late, and we are sharp on time for 1 hour. So thank you everyone for being there. Thank you, Manjula ji, for being there. Thank you, everyone.
Bye.
All right.
Have a very good night. Thank you, everyone.